hospital leader to address us will be Dr. Ralph Delatorre. Dr. Delatorre is the chairman and CEO of Steward Healthcare Systems, LLC. Thank you for being with us tonight. Your organizational specific question is, as a for-profit healthcare system, your owners will need your hospitals to make profits from their investment. Currently, your system is challenged to just break even. Please tell us your vision for ultimately creating a high-quality, affordable system that satisfies the needs of your owners as well.
Thank you. Thank you for bringing us all here today. So on the first question, our investors are just that, they're investors. They have bought into a system that we have created for the sole purpose of bringing healthcare to many of the most impoverished communities in Massachusetts. So how is it going to happen? We have to be better at it, given the locations of our hospitals, given the communities that we serve, given the amount of disproportionate share and Medicare that we subtend. As far as profitability, and some of those in the audience know this, that was one of the most aggressively negotiated terms of the Steward acquisition. Martha Coakley, God bless her, to the death argued with service to make sure that over the first 3 years, Steward had really no drive to reach profitability. It was an investment that was being made in the community, and that is what's been happening for 3 years. The hospitals are on target, the system is on target, exactly where we had hoped to be. If we had made money in the first year, it would not have been appropriate for us to have been in Massachusetts. We needed to build a foundation and an infrastructure, which we have. And we are very proud of where we're at right now. So what do we do to lower healthcare costs? It's who we are. Steward was a system that was created for the sole purpose of bringing community care, high quality community care to the worst communities in Massachusetts. So we have integrated physician networks, most of them which are private practice. We subtend over 1.2 million primary care lives in our panels, all in the communities. Our hospitals, on average, are well below the median in cost. Our TME is below the median. One of the largest expenditures we did early on was a massive IT integration within the capability across all of these systems. It is a much more difficult task to roll out a massive IT platform in Brockton where everybody is a private practice physician than in an academic setting where the vast majority are employed and in downtown Boston. It is much harder. And that is what we have strived for. That is what we have tried to do across our entire system. Payment reform. Virtually all of our contracts right now are global risk cap. They have been for years. Our negotiations now with the payers are not about whether we're going to accept global risk cap. It's about how do we get our cost savings back to the patients. It's about how does our TME translate into a premium saving? How are we going to do this? Are we going to do this on a percent of premium? Are you committed, if we lower our cost, to lowering the cost to the patient? That is our critical issue. Furthermore, the proof's in the pudding. If you look at behavioral health, if you look at some of the most needy components of what has existed or lacked in our community, that is where we have put our money. Why? Because in our vision, we own a community. When we're in Brockton, it is our responsibility to give care to all of Brockton, no matter what that might be. And that includes behavioral health, that includes surgery, that includes everything. We are not in a position to put select offices or select specialties in communities that drive revenue. We are not a revenue-based system. We are not a revenue-based system.